Good morning, everyone. My name is Gloria Ye, and I'm the Director of Clinical Research at the Osher Center. Thank you so much for joining us this morning for our Grand Round series. So before we get started, I just wanted to make a couple of announcements. First, you may have heard this already as we made the formal announcement at the beginning of last month, but the Osher Center has changed its name from the Osher Center for Integrative Medicine to the Osher Center for Integrative Health. And this was better to better align with the interests of the Bernard Osher Foundation and the 11 international centers of the Osher Collaborative that we're a part of. So you may see some of our materials and communications start to reflect this change, but it might be an ongoing process for the next several weeks. But rest assured, we're still the same Osher Center. The second announcement is that the Osher Center has compiled a short feedback survey that we've sent out to our mailing list, so you might have received that. And we're really looking to better understand how we might serve our audience and members of the Osher community better. So what your interests are in the Osher Center's work and what types of services and programs you find most useful. So please help us by filling out that survey. And there should also be a survey link in the chat box today, so you can take a look at that. For today's lecture, if you are seeking CME credit, please email hmsoshercenter@partners.org. And as usual, if you would like to pose a question to our speaker, please use the Q&A function in Zoom and not the chat box. Okay, so without further ado, it is my pleasure to introduce my friend and my colleague and our speaker today for our Grand Rounds, Dr. Maryiln Moy. Dr. Moy is a pulmonologist and associate professor of medicine at Harvard Medical School. She's the medical director of the Pulmonary Rehabilitation Program at the VA Boston Healthcare System. She earned her MD from Harvard Medical School and her Master's of Science in Epidemiology from the Harvard Chan School of Public Health. Dr. Moy studies the role of physical activity in the risk stratification of COPD, technology-based interventions to promote physical activity, virtual delivery of pulmonary rehabilitation, and the biological mechanisms underlying the beneficial effects of physical activity and exercise on COPD outcomes. As the principal investigator on VA and NIH-funded grants, Dr. Moy published one of the first papers demonstrating that low physical activity is associated with increased risk for acute exacerbations in COPD. She's also the developer of a novel internet-mediated pedometer-based intervention to promote physical activity in COPD. Dr. Moy is internationally recognized as an expert in pulmonary rehabilitation, and she's been an invited speaker at multiple international congresses, was former chair of the program committee of the Rehabilitation Assembly of the American Thoracic Society, and she's won numerous awards for her work. So I've had the great pleasure to work with Dr. Moy over the past several years on our studies of Tai Chi and mindful movement in patients with COPD, which I know that Dr. Moy will touch on today. So welcome, Marilyn, and I really look forward to your talk this morning.
Great. Thank you so much, Gloria, for that introduction. I'm going to share my screen. Can you see my screen?
Yes.
Great. Okay. Yeah, great. So I'm pleased to have this opportunity to talk about meditative movement in COPD, pulmonary rehabilitation, and physical activity. Okay, great. So these are my disclosures, including my grant funding that Dr. Ye mentioned from VA Rehab R&D as well as the NIH. I also currently serve on a data and safety monitoring board for a physical activity study. So I have three objectives today. I would like to talk about understanding the key roles of pulmonary rehabilitation and physical activity promotion in the management of patients with COPD. And then having established that underlying framework, I want to examine the evidence for the role of meditative movement modalities such as yoga and Tai Chi in pulmonary rehabilitation. And then finally, explore the potential role of meditative movement modalities in physical activity promotion. Now, I want to say that for this talk, meditative movements will include both Tai Chi and or yoga, and limited to these modalities because that is where the most published literature exists. So we'll start with pulmonary rehabilitation. This is the clinical practice guidelines from the American Thoracic Society that was recently published, and it highlights that pulmonary rehabilitation is standard of care for our patients with COPD. We know that pulmonary rehabilitation significantly improves symptoms of shortness of breath, improves exercise capacity, as well as health-related quality of life. It's notable that it is the only non-pharmacologic intervention associated with improvements similar to those that we've seen in trials for drug treatments for COPD. It is cost-saving. Pulmonary rehabilitation has been shown to decrease healthcare utilization, including decreasing risk for acute exacerbations and hospital admissions. Similar to smoking cessation and supplemental oxygen use in patients with resting hypoxemia, pulmonary rehabilitation is associated with a reduction in mortality in patients with COPD. Any individual with chronic lung disease who experiences breathlessness that affects their functional status and health-related quality of life is eligible for pulmonary rehabilitation and should be referred to a program. So what is pulmonary rehabilitation? So again, it's important to understand this framework so that we can see how meditative movement modalities could be used as alternatives or as an adjunct to pulmonary rehabilitation. Pulmonary rehab is a multi-component, multidisciplinary intervention comprised of supervised group exercise training, as well as education on disease self-management. Now, I acknowledge that pulmonary rehab will not reverse the underlying disease, specifically in COPD, by definition, an irreversible obstructive lung disease, and pulmonary rehabilitation will not, bring back the destroyed emphysematous lung. But pulmonary rehab tries to break the cycle of inactivity with exercise and education. So we know that the less that our patients do, the more their muscles become weaker, and then those weak muscles will need to use more oxygen to become more efficient, because currently they are less efficient. They tend to feel breathless because of that through very complex mechanisms. And then understandably, patients become fearful that any activity that they will do will make them more breathless. And so they tend to avoid these activities, and that the cycle goes on and on. And that's when these patients present to us in pulmonary rehabilitation. They present with symptoms of breathlessness. They present with a significant component of deconditioning. Again, we're aiming to reverse the deconditioning because we're not able to reverse the underlying disease. And so we're trying to help patients do the most with what they have. There's also, with the education, we target biopsychosocial aspects. And so through our education, we do touch on fear on exercise self-efficacy and confidence. So these are pictures from our pulmonary rehab program here at VA Boston. As you can see, these are the cornerstones of the exercise component of any pulmonary rehabilitation program. So there's the aerobic exercise training, which is key. Our patients use our stationary exercise equipment here. You can see the stationary bicycles. We have our treadmills. We have arm ergometers, and we help them progress. So our program is pretty typical. It's 2 times a week for 9 weeks, so that's 18 sessions. And during that time, we're trying to progress their exercise training. And we use their dyspnea level using the modified Borg rating to try to get them to do more each time. Most of our patients have cardiac comorbidity, and they're on beta blockers. So it's very difficult to use the heart rate as a reliable measure of their response to exercise. There's also stretching and range of motion, the strength training, which is comprised of, was used during the warm-up as well as cool down, as well as a dedicated time for strength training. And we meet our patients where they are. And for example, this patient here is using our resistive bands. Other patients are using free weights. We target both upper and lower extremities. And then these are, and when patients are exercising, these are unique opportunities to educate when they're symptomatic, right? This is so different than when we see them in our offices, in our clinics when they are at rest. So these are teachable moments when we can talk about pacing, paying attention to their breathing, and certainly trying to be aware of any chronic pain sites so that we can help them be most active. As I mentioned, there is a significant education component to pulmonary rehabilitation. Um, these are potential topics that we include. So, for example, our nurse practitioner will talk about anatomy and physiology of the lung, or one of us pulmonologists will talk about COPD exacerbations. It's a multidisciplinary group, and so we also have a respiratory therapist who's dedicated to the program, and she will talk about oxygen therapy. Our physical therapist will talk about exercise safety, certainly about home maintenance. And then we have our pharmacists and nutritionists give talks on medication as well as nutrition. And then we also have a dedicated behavioral psychology team who give our talks on coping with lung disease and maintaining an active lifestyle. Those 9 weeks with us are very short. And so from day one, we're trying to look ahead and see how these patients are going to continue their exercise after they leave us. And one of the huge barriers we know is just about long-term adherence and trying to make exercise a habit. And so this is what our behavioral psychologists and all of our staff are trying to teach and target from day one. And so despite the proven benefits of pulmonary rehabilitation, it faces many challenges. And these focus around the areas of access and adherence. And I think these are the key areas where meditative movement modalities can have a huge role. And we'll talk more about that in a little bit. But we know that programs are typically based at medical centers or outpatient medical offices. They require specialized resources in terms of exercise equipment. And we are asking our patients to come to us 2 to 3 times a week. We know that in a nationally representative sample of Medicare beneficiaries, 2/5 of older adults with COPD have poor access to pulmonary rehab, which is obviously more pronounced in rural areas. Programs are typically located in densely populated urban areas. And in fact, in this 2012 paper by Nishi et al., only 3.7% of Medicare beneficiaries used pulmonary rehab. So there's a huge issue of access. And then for those patients who actually get to us, there are non-completion rates as high as 20 to 40%, depending on the paper that you read. And so initial and long-term adherence are also significant problems for pulmonary rehabilitation. This is a map that is borrowed from Dr. Pantieri from the NHLBI. It highlights the lack of pulmonary rehab access. So these are sites that are certified by the AACVPR, which is the American Association for Cardiovascular and Pulmonary Rehabilitation. They're designated here with the blue dots. And you can see here that they are clustered here in the upper Midwest and the Northeast, certainly less dense in the Southeast and the Midwest, and even on the West Coast, where we know there are a plethora of COPD patients. So it turns out that in the US, there are only 830 certified pulmonary rehab centers for the estimated 24 million individuals with COPD. That boils down to 1 center per 43,000 patients. I'm proud of the fact that VA Boston is actually the only VA pulmonary rehab program that is accredited by the AACVPR. And then in terms of adherence, so these papers have identified independent risk factors for low attendance and high non-completion rates. And again, I present these because they can be potential targets for meditative movement modalities. So we know that current smokers, patients who are more short of breath at presentation, those who have depression, those who have had more previous hospitalizations are more likely to be non-completers. Certainly program-specific characteristics like the duration of the program and the distance of the program from the patient's home are also predictive of low attendance and non-completion rates. What I found most interesting was that these characteristics are not predictive, and these include age, gender, comorbidities, their underlying respiratory diagnosis, their disease severity, exercise capacity, health-related quality of life, and body mass index at baseline are not predictive. And so we really want to make sure that we're not making any generalizations when we're or stereotypes when we are seeing patients in front of us who are elderly, very frail, who lugging their oxygen tank and are quite limited, that those actually may be the patients who would benefit most and would be the people who are most engaged and would complete a pulmonary rehabilitation program. And if they are interested, should be referred. So having talked about the foundations of what pulmonary rehabilitation is and what some of the barriers are, I wanted to move on to one of our key questions in terms of our objectives today is, can meditative movement be an alternative to pulmonary rehabilitation? Okay, so we certainly know that meditative movement modalities are more effective than usual care in patients with COPD. There's an abundance of literature for that. But the effect of meditative movements in direct comparison with pulmonary rehabilitation is currently quite unclear. And again, I'm focusing uniquely on yoga and Tai Chi as meditative movements for my following slides. So let's take a look at some of the characteristics of meditative movements and see where they are similar to and where they are different from pulmonary rehabilitation. So certainly they are both holistic approaches that involve physical activity, and they both involve breathing exercises. They're both focusing on behavior change techniques. Trying to adopt exercise and physical activity is a significant behavior change. They both use psychological support to improve disease outcomes and disease self-management, and they both focus on promotion of self-care. They have both been shown to be relatively safe, but where there are differences are that meditative movements have varying degrees of aerobic exercise intensity. We'll talk a little bit more about that on the following slide. It tends to focus more on core strengthening, and I think these are strengths of meditative movement that can be learned from in the pulm rehab arena. So they also, as you know, meditative movements have focuses on physical postures, balance, focused attention and meditation, mindfulness, and relaxation. Certainly in pulmonary rehab, we want to have these outcomes be related to the program, but they're more of a positive, indirect side effects if they're attained. They're not directly focused on. So we use aerobic exercise training for our core component, and hope that as a result of that exercise training, that patients will be more meditative or improve their balance and posture, but we don't directly focus on that in pulmonary rehab. So for any program, in addition to meditative movement ones, in order to be an alternative or / replacement to pulmonary rehab, it would need to maintain fidelity to the key components of conventional pulmonary rehab, which have been shown to be efficacious. So these 4 components would be the aerobic exercise training, the strengthening exercise, education, and social support. So there's the greatest literature on the exercise component of meditative movement modalities. So let's take a little deeper dive into that area. So we know that in COPD, it has been shown that Tai Chi can achieve moderate levels of exercise intensity at approximately 64% of VO2 max. It's been shown Tai Chi to be physiologically similar to constant rate walking on a treadmill at 60% of maximal load. So it can potentially be an effective exercise training modality in a subgroup of our patients with COPD. In this study, which I found very interesting, these authors actually compared Tai Chi, which is represented here in the red line, to treadmill walking exercise, which is represented here in the blue line. They tested patients over the course of an hour, and they compared oxygen uptake, diaphragmatic electromyography, as well as esophageal pressure swings during these exercises, and looked at the between group differences. They showed that, as you can see, they are essentially the same. And so this is very reassuring and promising that Tai Chi can be potentially an alternative to aerobic exercise training in pulmonary rehab. For strength exercise, there's no literature to help guide us on this. We know that meditative movement modalities are more weight-bearing and don't require any equipment, which is one of its strengths. So, in comparison to the resistive bands as well as the free weights, it's unclear whether they are equivalent. Certainly the Tai Chi and yoga have not been incorporating education that to as what I've described for pulmonary rehab, understandably, but I could imagine that in a program that incorporates the meditative movements, we can easily use the education that we currently have for our conventional pulmonary rehab programs. For social support, pulmonary rehab is group exercise. But while yoga and Tai Chi can be performed individually in patients' homes or in group settings, so it could be it can be viewed as being maintaining fidelity to the social support part. Okay, so then, as I said, there is a dearth of literature on. Sorry, did I skip a slide here? Yes. So in terms of outcomes, we also want to, in addition to maintaining fidelity to the core components of pulmonary rehab, we want to look at the different outcomes that are similar to in pulmonary rehab as they are in the meditative movement modalities. So on the left is a list of outcomes that I included if I found at least one paper that looked at it compared to usual care in Tai Chi and or yoga. And as I said before, it has definitely been shown and widely accepted that they are better than usual care. And so again, thinking about it, thinking about them as whether they could be replacements for aerobic exercise, we would want to look at these outcomes in those direct comparisons. So certainly, Tai Chi has been shown to enhance lung function. This presumably is because of the slower, deeper breaths that patients are taking and presumably helping clear secretions, for example. Inspiratory muscle performance has been shown to be improved by Tai Chi. Exercise capacity has been shown to be improved with improvements that are similar to those seen in pulmonary rehab. So there are published literature that shows that there have been increases of 25 to 30 meters, which is in the MCID range for the 6-minute walk test distance. There have been improvements in physical activity, health-related quality of life, dyspnea scores. As I mentioned, breathing patterns are very important. When patients are exercising on a treadmill, we do encourage them to take slower, deeper breaths because the reflex is to take faster, slower, shallow breaths, and we don't want patients to be ventilating dead space while they're exercising. And so that is one of the strengths of yoga and Tai Chi, is that it is inherently trying to have our patients adopt this breathing pattern. Certainly anxiety, depression, sleep quality, and fatigue are important outcomes for both modalities, pulmonary rehab and meditative movements. And then there's also, I did find a paper looking at COPD acute exacerbations and Tai Chi, showing that there are decreased risks in terms of associating the meditative movement with this hard outcome. So these outcomes that I listed on the right are ones that are definitely inherent to meditative movements. We try to capture these in the education portion of pulmonary rehab, but they are not directly assessed, nor have they been rigorously tracked in the pulmonary rehab literature. So self-exercise, self-efficacy, motivation, confidence, awareness of the body and breath, adaptive reframing of breathlessness, fear and embarrassment, and then cognitive aging is an outcome that can be improved with the meditative movements because patients are asked to remember sequences of movements. This is something that we don't ask patients to do in pulmonary rehab, so this may actually be in favor of the meditative movements and could be used in programs to focus on cognitive aging and brain health. We talked a little bit about access and adherence already. Can meditative movements help be an adjunct or alternative to pulmonary rehab to increase access? It can be performed individually at home, and so can be community-based. We know that socially and culturally contextualized Tai Chi is widely performed and adopted in China, and yoga is widely adopted in India. And so in resource-scarce countries, for example, where there are not exercise equipment, these meditative movements may improve access. And then certainly short and long-term adherence are areas that require more study in terms of where meditative movements can be helpful. So I wanted to take a closer look at this one study, which compared directly Tai Chi and pulmonary rehabilitation head-to-head. This was published back in 2018, led by Dr. Polkian and His group in the UK, the study was actually performed in China. And what he did was they hypothesized that Tai Chi would be equivalent to Tai Chi, to Pulm Rehab. And their primary outcome was health-related quality of life. I'm sure you're all seeing this, measured by the St. George's Respiratory Questionnaire total score. And here, the lower the score, the better the health-related quality of life. And they enrolled 120 patients who were bronchodilator naive. Their mean FEV1 was 44% of predicted, so moderate level of obstruction. And these patients were all started on 2 weeks of Indicatorol. And then at that point, they were randomly assigned to either standard pulmonary rehab 3 times a week or group Tai Chi class 5 times a week for 12 weeks. And so they followed them at 12 weeks, and then after the intervention ended, they followed them for an additional 12 weeks at 24 weeks. And you can see here, they found that at 12 weeks, Tai Chi is equivalent to pulmonary rehab with respect to St. George's Respiratory Questionnaire total score, which again is a measure of disease-specific health-related quality of life. And at 12 weeks after the intervention ended, they found a clinically significant difference in health-related quality of life, which favored Tai Chi. And then this between group difference was actually statistically significant as well. It reached the MCID difference of 4 units on the SGRQ, but it was also statistically significant. And this was similar in terms of patterns for the other secondary outcomes that this paper took a look at. So they concluded that Tai Chi is equivalent to Pulm Rehab, and they went on to say that Tai Chi is an appropriate substitute for Pulm Rehab. Back in 2018, this drew quite a backlash, mostly because it didn't maintain fidelity to all the other components of Pulm Rehab. But nevertheless, it remains an important foundation in terms of adding to the literature of ongoing inquiry in this area of whether Tai Chi and or yoga should be considered alternatives and replacements to pulmonary rehab. At around the same time, this Cochrane review came out looking at active mind-body movement therapies as an adjunct to or comparison with Pulm Rehab. And unfortunately, they concluded that basically that the literature was inconclusive. And I thought it was interesting that the reason why this was the case was that the comparator groups that they were being used in the 10 papers that they included in this Cochrane review were quite heterogeneous in how they defined pulmonary rehab. So in some papers, Pulm Rehab was often considered equal to unstructured walking training. And so because of that issue in terms of the comparator group, they were not able to make any conclusions. But they did suggest that in those 10 studies, which involved 762 participants, that compared to Pulm Rehab, there were larger improvements in disease-specific health-related quality of life, were observed with the meditative movements, although meditative movement was not superior to Pulm Rehab alone with regards to the symptoms of improving shortness of breath. And then as an adjunct, when these meditative movements were added to Pulm Rehab, compared to Pulm Rehab alone, they found that there was a suggestion that there were improvement in generic health-related quality of life, but no further improvements in disease-specific health-related quality of life. So moving on to our next question about can meditative movements be an adjunct to Pulm Rehab? There is, again, not a whole lot of literature on this, but I wanted to share this paper, which is put forth by Dr. Sally Singh and her group in the UK, where she actually published a framework of recommendations for integrating yoga with Tai Chi, with pulmonary rehab. And as you can see here, I really like this model. And it shows how we could fully integrate yoga with a Pulm Rehab program. And so we could imagine that the breathing techniques, which are part of yoga, could be used during the Pulm Rehab warm-ups and cool downs, and that when patients are on their aerobic exercise training equipment, that we can use the yoga breathing techniques to help patients with their shortness of breath. Currently in the VA Boston program, for example, we have 3 15-minute sessions where patients are rotating between the equipment. I could easily imagine how one of those 15-minute sessions could be dedicated to the yoga postures so that we can focus on balance and flexibility. And certainly during the resistive training parts of pulmonary rehab, we could be alternating on days of the week, alternating with the stretches and other components of strength, flexibility, and balance that yoga provides. And certainly on the days, our program is, which is typical, is 2 days a week, Tuesdays and Thursdays. So what are our patients doing on the other days? So I could imagine that we could be asking patients to perform their yoga or Tai Chi program on those days so that not only will it improve the outcomes that we talked about independently of pulm rehab, but when they show up to pulm rehab, that they would be actually able to use the equipment in a better way in terms of being able to maintain their balance, that it would be safer, that they would come to us with more flexibility, for example. And then finally, so this is a paper that looked at full integration of Tai Chi, so not yoga, but this is Tai Chi and pulmonary rehab. And this was published just this month. So I wanted to show, just to talk a little bit more in depth. So this is a single-blinded randomized controlled trial that recruited patients with mild to severe stable COPD. So they were able to enroll 120 participants, and these patients were randomly assigned to one of 4 groups. So either usual care, a total body recumbent stepper exercise program, Tai Chi alone, or a combined total body recumbent stepper exercise program and Tai Chi. So the intervention lasted for 2 months, and then they continued for another additional 10 months in the community. And they found that the mean changes in health-related quality of life, again, using the disease-specific St. George's Respiratory Questionnaire total score, showed a statistically significant difference between groups in favor of the combined total body recumbent stepper and Tai Chi exercise group. They found that this benefit in favor of the combined group was maintained at the 12-month time point as well. So I think this is a very encouraging data to looking at the combined modalities of meditative movement and pulmonary rehab, and hopefully there will be more studies like this coming out in the future. And then in terms of, again, pulmonary rehabs, I'm just having a hard time advancing here. So in terms of one other question that I wanted to look at for pulm rehab, where Tai Chi could be a solution, is this issue of maintenance of benefits after patients complete pulmonary rehabilitation. So we know this from this study published way back in 2006, that when patients stop doing any kind of regular activity after they finish a pulm rehab program, that benefits start to decline as early as 3 to 6 months. So here we look at shortness of breath, represented here in this figure, and we have irregular walkers in the dotted line compared to regular walkers in the solid line. This was a study led by Dr. Andy Reese at UCSD, and you can see here that patients' shortness of breath starts to increase linearly as soon as they stop exercising. So we looked at this question. So Dr. Ye and I, through this study funded through the NCCIH, looked at whether Tai Chi can maintain benefits over the long term after patients complete a pulmonary rehab program. And here we were able to randomize 91 patients to either to one of 3 groups. So this was 2 to 2 to 1 to either Tai Chi, usual care, or group walking for 6 months. So this is 24 weeks. And as a cohort, these patients had a moderate level of obstruction. So their FEV1% predicted on average was 48% of predicted. Their mean age was 69 years old. And our primary outcome was 6-minute walk test distance at 6 months. And we found that there was a small between group effect size in change in 6-minute walk test distance that favored Tai Chi compared to usual care. Although this difference was not statistically significant, the p-value was 0.10. We did find that there was a greater percentage of participants in the Tai Chi group who improved their 6-minute walk test distance at this time point compared to usual care. So 64% versus 39%. And so we do feel that Tai Chi could be a feasible option to maintaining benefits after patients complete a pulmonary rehab program. And we know that these programs are, at our local YMCAs, and they are a part of our whole health program here at the VA, and so can be readily accessible to our patients. So in this last part of my talk, I'm going to focus on physical activity promotion and shift our gears from pulmonary rehab and talk about how physical activity promotion in and of itself is an important endeavor in our patients with COPD, and again, how meditative movements can be looked at as alternatives or adjuncts in this area. So physical activity is defined as any bodily movement produced by skeletal muscles that results in energy expenditure. So physical activity includes exercise that's planned, structured, repetitive, and purposeful. But in our patients with COPD, this includes preparing a meal in the kitchen, walking down the driveway to collect the mail, walking in the hospital corridor to go to a medical appointment. So it's not limited to just the aerobic exercise that they're performing at a gym or in pulmonary rehab. So I became very interested in physical activity back in the early 2000s because of this common scenario. So 2 patients with COPD, both maximally optimized on pharmacologic treatment with the same exact lung function, who have differing levels of physical activity and function at home. So this person on the left is essentially bedbound, while the person on the right is able to exercise at a gym. And we may not even appreciate these differences by seeing them episodically in the clinic every 3 to 6 months and performing our hospital-based tests. So at that time, the wearable sensors came out onto the market. And so we'd leverage those to assess and to characterize what patients with COPD were actually doing at home. So in this study, we had our patients, this was about 140 patients with COPD who span the range of disease severity, wear both an accelerometer and a pedometer for 2 weeks. And we were able to characterize what they were doing at home. And we see that in this histogram, the median daily step count was about 5,250 steps per day. So this is significantly lower than the 10,000 steps per day recommended by the CDC to maintain health. So we went on to see whether daily step counts objectively measured could tell us unique information different from our current measures of COPD status. So here we see plotted on the x-axis the percent predicted FEV1 of that same cohort, and then average daily step counts on the y-axis. And you can see here that there is a linear relationship between increasing FEV1 percent predicted with daily step counts. But what was really striking to me was that for any given level of lung function, there was this widespread in average daily step counts. This is similar when we look at 6-minute walk test distance or health-related quality of life. And so we concluded that daily step counts does capture information that's unique from our clinic-based tests, as well as our patient self-reported patient-centered assessments. So we went on to look at daily step counts and its association with acute exacerbations in a veteran cohort. So these events, acute exacerbations and COPD hospitalizations, are what cost society the bulk of healthcare dollars spent in COPD. So if we were we're going to convince providers as well as policymakers that physical activity is an outcome that's important in COPD, we wanted to look at these relationships. So we followed 169 patients with COPD over a median of 16 months. So every 3 months, we called them on the phone and we asked them about the occurrence of these events in the previous 3 months. And we were able to verify over 86% of the exacerbations and over 95% of the hospitalizations with medical records. And we found, we found that of the 169 patients that we enrolled, that 90 participants had 212 exacerbations and 118 hospitalizations were found in 60 of those participants. And using negative binomial regression models, we looked at these relationships between daily step counts and these events. I present 2 models here. One is the continuous variable model, and then the other is daily step counts categorized in quartiles. And you can see here that compared to those who walk the most, those patients who walk the least had a rate ratio for acute exacerbations over 2. And an increased risk for COPD hospitalizations that was with a rate ratio of 6. And I want to emphasize that these were every steps walk. These were not aerobic exercise steps. These were every steps counted. We're using our accelerometers during these assessments at home. I'm going to speed through these next few slides just in this interest of time. But these show that daily step counts and physical activity are also important in predicting survival. So in this study by Dr. Waschke and his group in Germany, they categorized patients as active, sedentary, or very inactive according to the World Health Organization and follow them over 4 years. You can see with these Kaplan-Meier curves that separation occurs very early on, and that compared to those patients who are active, patients who are sedentary or very inactive had a much lower probability of survival. In this paper that led by Dr. Wynn and her group at Kaiser Permanente, Southern California, they looked at patient-reported physical activity. So in that healthcare system, patients are asked routinely at their outpatient visits, on average, how many days per week do you engage in moderate to strenuous rigorous activity? And on average, how many minutes do you engage in exercise at this level? And this total minutes of moderate to vigorous physical activity is entered into the chart as a vital sign. So they looked at over 4,500 patients and looked at the relationship between those patient-reported moderate to vigorous physical activity and risk for 30-day hospital readmission after an index hospitalization for COPD. They found that any minutes of patient-reported activity at that level was beneficial in terms of reducing risk for hospital readmission, with risk ratios of 0.67 and 0.66 compared to patients who reported 0 minutes of physical activity in the moderate to vigorous range. We use the same population, so this is looking at about 2,300 of those patients and followed them over 12 months and looked at survival. And again, the 0 minutes of moderate to vigorous physical activity reported by these patients is represented here in the blue line. And then these are patients who reported any minutes, so 1 to 149 versus greater than 150. And you can see here over the, this follow-up of 12 months, the Kaplan-Meier survival curves show that patients who exercised for 0 minutes compared to those who exercised any minutes had a lower probability of survival. So taken together, all of those literature helped basically put physical activity on the map for patients with COPD. So in 2007, the GOLD criteria showed did not mention physical activity at all. It did recommend pulmonary rehabilitation for patients with moderate or high or worse disease, but did not promote physical activity. But based on the body of literature I presented, we fast forward to 2013, physical activity is mentioned 11 times here, and physical activity is recommended for all patients with COPD. So again, remember, this encompasses every step taken as well as exercise specifically performed in pulmonary rehabilitation, for example. So when I move these bars, okay. So we wanted to, so my VA rehab funded research through Rehab R&D has focused on developing an intervention to promote physical activity in the COPD population, given the evidence that we just reviewed together. So we worked on developing a web-based platform to promote physical activity and couple it with a pedometer so that we could directly bring an intervention to our patients. So in designing this website, we worked collaboratively with Dr. Caroline Richardson and her group at the University of Michigan. And then we also collaborated with our patients. So we directly asked our patients with COPD why they did not walk more. And we wanted to understand these barriers so that we could address them in the content of our website. And we found that over a third of the patients endorsed at least one of these 3 reasons for not walking more. So they were worried that they would become short of breath. They were worried that they would need to use their inhalers, or that they were worried that they would need to, their oxygen would become low. And significantly, we found that patients who endorsed these worries and concerns walked 1,300 to 1,800 fewer steps per day than patients who did not endorse one of these concerns. And that's well within the MCID for daily step counts, which has been shown to be between 600 to 1,000 steps per day. So this is the conceptual model for our web-based platform. It is based on the behavioral theory of self-regulation, which emphasizes an iterative process of behavior change. So it focuses on individual tailored goal setting, feedback, education and motivational messaging, as well as social support. And these 4 components are represented here on the homepage of our website. Goal setting is in the form of concrete step count goals. Patients are asked to wear their Fitbit every day and then to upload their step counts to our study server at least once a week. And then every Sunday morning, they get an updated step count goal, which is very concrete. So it's 5,700 steps per day. That's what they need to achieve for the upcoming week. They get feedback on the face of their pedometer, or they can come to their homepage and look at their cumulative progress over the past weeks to months. And then the social support is in the form of online community forums, and motivation is in the form of educational messages. You can see here, this is, so this is the exercise component, which again, we have an automated algorithm that increases their step count goals every week, depending on what they upload. So it's current. We ask them to exercise, to walk with an intensity of between 4 and 5 on the modified Bohr rating. And of course, we advise them that if you can't walk at this moderate intensity, not to worry, and that any walking is at any intensity is better than not walking at all. And then this is an example of one of our educational tips. These were developed in combination with our behavioral psychologists as well as pulmonologists. And we try to mirror the content of what we deliver in pulmonary rehabilitation. So these are topics such as wearing oxygen while you're walking, early identification of COPD exacerbations, managing symptoms of dyspnea, for example. One of the benefits of having it on a website is that patients can access this content 24/7 from the comfort of their homes. So if they have a question, instead of waiting for the next home rehab session, for example, they can turn on their computer and go review the content on their own. This is an example of our online community forum. So here, either both the staff and the patients post content to encourage each other to start their walking and to achieve their goals, and to walk when the weather gets colder and the days get shorter, for example. So this is a great place for them to come to be able to motivate each other. So this platform has been shown to be efficacious in 3 different randomized controlled trials, again, all funded through VA Rehab R&D. Our first trial was published in 2015 in CHEST. This is, again, 2-arm trials between group comparisons. Our second trial was published in 2017 in Respiratory Medicine, and then most recently in 2021 in the European Respiratory Journal. And we showed that the average between group difference was about 1,200 to 1,400 steps per day in our intervention arm compared to our usual care arm. Now, for you skeptics in the audience, you probably think that is not a whole lot of steps per day. But we went on to show that even this modest increase in steps per day, again, which is within the MCID for daily step counts, in this frail population, it was significant in terms of improving risk or decreasing risk for future COPD exacerbations. So compared to usual care, patients in the intervention arm, when followed over a median of 12 to 15 months, had a reduced risk for COPD exacerbations because of this increase in walking of 1,200 to 1,400 steps per day. The risk ratio was 0.51. So having talked about the foundation for promoting physical activity, I wanted to focus in this last 5 minutes or so of my talk on whether meditative movements can support physical activity promotion. And again, there's the short answer is nobody really knows. There is a huge gap in our knowledge base, and there is I couldn't find any literature looking at physical activity promotion in COPD along with Tai Chi and or yoga. But what I am excited to present here is two newly funded trials that will take a look at this question. The first one is led by Dr. Ye at Beth Israel Deaconess Medical Center, and it's called Mindful Steps. And so this is a web-based mind-body exercise intervention to promote physical activity in chronic cardiopulmonary disease. And so this intervention is coupling the Every Step Counts platform that we just reviewed with Tai Chi, with mind-body exercise. And so the goal is to see if this would be efficacious in promoting physical activity in sedentary patients with COPD and or heart failure. The intervention is 12 months long. There are many secondary outcomes, as you can see here, including self-exercise, self-efficacy, intrinsic motivation, mindfulness. There are qualitative interviews that will be conducted, as well as dyspnea, fatigue, and tracking COPD and heart failure exacerbations. This is the conceptual model for this study. As you can see here, the integration of the mind-body exercise with the Every Step Counts platform allows the incorporation of mindfulness into everyday activities. So in both walking and other activities of daily living. And the hope is that this would promote long-term adherence to physical activity. Again, we're following these patients over 12 months, a whole year. And the hypothesis is that this integration would enhance existing behavioral constructs as well as target new behavioral ones through self-reflection and personal transformation, looking at the experience of walking, goal attainment, intrinsic motivation, as well as mindfulness. And the hope is that this would increase exercise self-efficacy and ultimately improve long-term physical activity adherence. The intervention is comprised of mind-body exercise classes. This is the frequency is once per week in weeks 1 through 6, once every 2 weeks during weeks 7 to 40, and then one class per month at the end in weeks 41 to 52. This is the second trial that is about to be launched. This is a study called WATCH. This is walking and Tai Chi for pain in patients with comorbid COPD and chronic musculoskeletal pain. This is a study funded by VA Rehab R&D, and we're trying to target a specific population here. So these are the subgroup of patients with COPD who also have comorbid pain, because we have shown that in our previous trials that not everybody improves with our Every Step Counts intervention. And so for our patients with chronic musculoskeletal pain, we're asking, can the addition of Tai Chi be able to increase their physical activity and decrease pain intensity? So this is a 6-month trial. We're looking at the primary outcome of physical function measured by daily step counts. Again, there's a plethora of secondary outcomes, including measuring directly exercise self-efficacy, kinesiophobia, and pain catastrophizing. This is the conceptual model for this trial. Again, trying to combine the strengths of both modalities of walking as well as Tai Chi with the hypothesis that this combination will increase physical function, decrease pain intensity, as well as ultimately, through these mechanisms, a decreased risk for acute exacerbations. In this intervention, we are modifying Every Step Counts with pain content. And in months 1 to 2, patients are asked to use the website and to watch the Tai Chi videos. And then in months 3 to 4, when they've gotten their walking down, we're adding Tai Chi classes once a week. And then in months 5 to 6, when they are, again, have brought in the Tai Chi classes and the walking into their, hopefully in terms of their, part of their behavior change, then we're increasing the Tai Chi classes to twice a week. So we are very excited to conduct these trials and roll them out. And we look forward to presenting these results, hopefully at a future Osher Center Grand Rounds. So I'll end by thanking my collaborators at the Osher Center, Dr. Jay and Wayne, as well as Dan Latrownik, my research team here at VA Boston, as well as my clinical pulm rehab staff. I want to thank all our veterans who've engaged in pulm rehab, and our research studies. And thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Marilyn, for that talk. Really amazing the breadth of evidence that you that you reviewed, and really exciting studies that we're both doing together moving forward. So we don't have a ton of time, but some time for questions, and there have been actually a lot of questions, and so I'm going to try to maybe put some of these together. We probably won't get through them all, but the first one is about actually the integration of meditative movement together with pulmonary rehab. And so, you know, as part of our work as well, you know, we looked at the LEAP trial, it was really meditative movement after pulmonary rehabilitation, but you showed that nice figure of the integrated yoga program. And so the question is, you know, I think in the past we thought, well, you know, there's only so much somebody can do at once, but maybe we could really integrate them in a thoughtful way. And so the question, a couple questions. One regarding that is, do you think that patients would adhere to that? Like, is that too much for folks? And then at the same time, like, do you know of any? One of the questions was, do you know of any sites that are actually doing some sort of an integrated meditative movement in their pulmonary rehab now?
Yeah, thank you for those questions. So I do not know of any sites currently that fully integrate the way that we have presented. I do know that many sites, including ours, you know, our patients will finish our program and go on to use you know, yoga and Tai Chi modalities to try to continue their physical activity. In terms of your first question about whether patients would be accepting of that, I think so, and we won't know until we try. But certainly, you know, if we were doing it and this is our program, you know, patients would follow suit. And my only concern is that, you know, would we have the staff to actually, you know, be rigorous and deliver the Tai Chi and yoga the way that it needs to be, and you know, as opposed to training our physical therapist or our nurse practitioner to do those teaching and have a, I think, a watered down version, and maybe not as good a version as, you know, what you and your teams can deliver, for example. So, you know, that being able to incorporate staff into an actual pulmonary rehab program would be, you know, something that needs to be addressed. But I would be excited to actually try to adapt our program and really do a study, or even maybe even, you know, whichever patients are willing to have them be assigned to that group, and then compare those outcomes to a patient to the group who don't want to, and see what happens in the end.
I think we need to do that, Marilyn. I think that's our next grant. So, all right. So I'm going to try to get in another question. And this one was, so do you believe the Tai Chi movements also ameliorate anxiety, which is a component of COPD exacerbations, which is, the writer says, and do you highlight this for the patients? And that, I think that gets at maybe this anxiety breathlessness cycle that we sometimes talk about.
Yeah, so I'm not familiar in the literature that any study looking directly at the relationship between anxiety and the risk for COPD exacerbations. But certainly, you know, patients will become more short of breath with the cycle, you know, the cycle of inactivity I showed you. There's a similar cycle for, you know, anxiety and worsening shortness of breath. And so in our education, we certainly do address the anxiety and how to ameliorate that. But again, because we don't incorporate the Tai Chi and yoga into our classes specifically, we haven't been able to look at that. But certainly, you know, when patients are looking at using these modalities as part of whole health or on their own, they do use it to alleviate their anxiety. I know I didn't quite answer the question, but but we don't intentionally tell them that, you know, reduce your anxiety so that you'll have a decreased risk of acute exacerbations.
All right. We're at the top of the hour, and there's still more questions. So I guess you know, if you're willing to have some folks contact you afterwards or email you with questions, you can let us know. We can share your contact information.
I'm happy to share my email. Yes.
Okay,
I
wonderful.
can do it right here now, actually. Or, yeah.
Okay, you can put it into the chat perhaps. So I'm going to go ahead and just make a few sort of ending announcements. We do have a couple of very special grand rounds lined up, coming up, and one of them falls outside of our usual sort of first Tuesday of the month cycle. And actually both of them fall outside of our usual grand rounds time. So I just wanted to note them. So the first is on Monday, November 20th at 12 p.m. So we're going to have the Harvard Medical School Distinguished Lecture in Mind-Body Research and Health, jointly hosted by the Osher Center, the Benson Henry Institute for Mind-Body Medicine, and the Center for Mindfulness and Compassion at the Cambridge Health Alliance. And the speaker will be Dr. Evan Thompson, who is a professor of philosophy and scholar from the University of British Columbia. He's also the author of several interesting books on the philosophy of the mind. And he's going to speak on mindfulness meditation as embodied cognition, a view from cognitive science. Again, that's Monday, November 20th at 12 p.m. And the second grand rounds that I wanted to mention was the one next month, Tuesday, December 5th, but at 12 p.m. Again, with Dr. Robert Waldinger, who's a psychiatrist at HMS. He's also a Zen priest. And he has one of the top 10 most watched TED Talks on what makes a good life. And he's also the author of the recently published book, The Good Life: Lessons from the World's Longest Scientific Study of Happiness. So he'll be delivering our third annual endowed Kogan lecture on social connection and happiness. So you won't want to miss that. So again, that's December 5th at 12 p.m. And you can register for these upcoming grand rounds on our website, oshercenter.org. So with that, I would just want to thank you all again for joining us. And thank you so much, Marilyn, for your awesome talk. I'll see you all next time. Have a great day.